Hello, how's everybody doing? Dr. Peter Noël here. We're going to jam on some radiographs of small animal, dogs, cats. We're going to give you the opportunity to take a stab at what you think the diagnosis is. Some of these we know the diagnosis, the outcome, others we don't know. It's going to be sort of a mishmash. And I would encourage you to crank up the brightness on your monitor, turn the lights down in the room so it's kind of like a full moon. Get a cozy blanket and a glass of red wine and or not. If you don't imbibe, that's fine. Okay, you ready? First study, we got, I'm going to show you here. Give me one sec. Let's share my screen. It's going to be 3 views of the thorax. Some brachycephalic middle-aged dog presented for coughing. You can see on the left here, we got some follow-ups images, but I'm not going to show you what those are. Remember, there are wrong answers, so you can be totally wrong. And if you post your wrong answers in the chat, we will just make fun of you. And this will all be posted to YouTube. And so the 5 subscribers to the channel will also laugh at you. Okay, so make sure you take a crack. Coughing, acute onset coughing. Okay, here we go. Anybody got anything? I'm going to turn these Röntgen signs off. These Röntgen signs are great. They really help when you don't know what in the world you're doing. By the way, anybody read any good books? I'm reading this one called A Short History of Nearly Everything by Bryson. And I really don't know much. I spent so much time staring at radiographs and then a vet med textbook. Dr. Allen, complete consolidation of the left cranial long lobe and alveolar pattern, tracheal displacement to the right. Is there a bulle? Okay, so bulle, vesicular gas pattern. You were right. Lung lobe torsion, maybe, not sure. Left thoracic cavity, increased opacity. The goldfinch is good. The goldfinch, I've read the goldfinch. Could have used some editing, but I like the goldfinch, especially. I just moved not too long ago to a suburb just north of New York City, so that whole like antique New York City vibe was really nice. Okay, so in the left cranial thorax, there is an increased soft tissue opacity that completely effaces pulmonary blood vessels. That supports Doc Allen's alveolar pattern. So I think that's great. I love the fact, what did she say? Tracheal displacement to the right. So I think this trachea is probably, I mean, first you want to check spinous processes look like teardrops, right? So the way that I would approach this study is, as some of you have, where there's something wrong, something's rotten in the state of Denmark in this left cranial thorax, okay? So there's increased opacity here. But what's interesting is that these spinous processes are pretty straight, teardrop shape. So the dog's pretty straight. And for a sort of barrel-chested brachycephalic that's probably coughing and a pain in the ass, he's really straight. And the fact that he's pretty straight, you've noticed that this cardiac silhouette is on midline, and possibly you can hallucinate a little bit. Maybe it's pushed a little bit to the right, but it's certainly not pushed to the left. Remember, if you have an alveolar pattern and if you see an alveolar pattern, you have to ask yourself the next question is, what's the size of the lung lobe? If it's underinflated, like if it's occupying a smaller space than anticipated, then you could think maybe it's just atelectasis. If it's sort of the normal size or somewhat similar to the normal size, it's blood, pus, or fluid. If it's bigger than it's supposed to be, you should start looking for rounding, like a mass. But in this particular case, I think there's increased, it's a little bit of a punch over to the right here, and Ure was spot on with the stippling. So you'll notice on this radiograph, there's a very interesting finding. This stippling right here, you don't normally see that in pneumonia unless the lung lobe's necrotic. And so he called it a vesicular gas pattern. So if you see an alveolar pattern and you see the vesicular component, which are these stippled gas opacities, that should sort of perk your ears up. This may be a lung lobe torsion, and really you should not sort of just sit on this as pneumonia. It could be a necrotizing pneumonia. I think sometimes it can be hard to see if the bronchus is occluded or narrowed or malpositioned. But in this particular case, there's a vesicular gas pattern. I do wonder if there's a little bit of pleural fluid. You see a little bit of this kind of right in here. And the other thing that I thought was interesting is you'll notice that you can kind of still see the liver diaphragm margin here, but it kind of goes away here. So the pleural fluid, I think, is trace. I think that's probably a little bit harder. I wouldn't expect you to kind of to jump on board with that, but I would expect and hope that you'd see that there's an alveolar pattern, and you should go, oh, I wonder if the dog's got pneumonia. And then you flip it on your side and you're like, oh no, there's this stippling. Now I'm wondering that there's maybe a lung lobe torsion. I do think the bronchus is pinched up here. You can't see it. Normally, you have the trachea or the trachea comes down here, and you get this J hook, right? The J hook, you get the left cranial lobar bronchus, and then the caudal bronchus to the left cranial lung lobe gets this J hook. It's just gone. And then the other thing to consider is the lobe. So that left cranial lung lobe is game on for like pugs or the poster child. So we tend to think of right middle lung lobe for the Borzoi and Afghan hounds, maybe sight hounds tend to like the right middle lung lobe. The trachea is tortuous. I mean, it kind of undulates a little bit, but it's a normal diameter for this breed. I don't think that it's collapsed. This is the trachea right here, if you hallucinate with me. And, you know, it normally has a slight rightward, a gentle rightward bend. So I feel like that's totally fine. So acute lung lobe torsion, thoracic CT is ideal, just to be sure. If this was a necrotic lung lobe, to give you a little bit of the pleural fluid and vesicular component and not torsed, I still think it's probably best, or there needs to be a discussion about why it's necrotic, and it probably needs to come out anyway. All right. Cardiac silhouette is normal, no left atrial enlargement. Cranial abdomen is normal. The trachea, I think, is normal for the breed. I think the craniomediastinum is normal. Thoracic body wall is normal. Aggressive osseous disease is absent, period. These disc spaces here look narrowed, but boy, you got to be careful. Probably the esophagus with a little bit of gas in it would be my guess. There's the cava under it. Let's say you were like, well, is this a bulla? I would chill out on the bulla unless you can see the full circle. Benefit of the doubt, the dog's probably gasping for air. Maybe there's the line right there. That could be a part of the accessory lung lobe. That could be a pleural margin right there. That sort of bend is, it feels like it's got a little bit of gas in the caudal esophagus. Yeah, so the one that I had recently, a neoplasty with a secondary infection, there was a lung mass, or it was a pleural neoplasia with secondary infection, because that with secondary torsion, because that's what I would be worried about, is you get some sort of pleural neoplasia like a carcinomatosis or something like that, and then the pleural fluid causes that to be a little more buoyant, and then it swivels. But I suppose you have anything that disrupts that. This was the following day. Okay, so I wonder if this dog came in a little after lunch over the summer. So it was a lung lobe mass. Yeah. I wonder if this came in, they looked at it, they go, I wonder if this is pneumonia. So then they treated the dog overnight, and then it either was hospitalized overnight, but you'll see that over here the next day it came in, and then let's see what happened. Okay, so still there. Now there's a little bit of, I think it's a little bit easier to see that there's probably a little bit of fluid under there. Oddly looks maybe even a little bit better, which probably made everything a lot worse. I actually like this radiograph, this first one. I mean, you can still see the vesicular component on that follow-up, but this first one I think is kind of more classic. Left cranial, alveolar component, vesicular component, subtle rightward mediastinal shift. It's going the opposite way, and a little bit of fluid. Acute vomiting. It's a dachshund. 3 views of the abdomen. All right. Anything abnormal? So Dr. Walsh said there was a bone opacity, so mineral opacity in the small intestinal area. So I like, she used some Röntgen signs. She gave a location, small intestinal area, the opacity. Other things that you could say is that it's angular. I know a lot of you, if you're like me, didn't like doing surgery. I hated doing surgery, and so I would try to see if 12 hours of fluids could clear these things when I worked as an ER vet, and we had to cut overnight. And I noticed that these angular mineral ones hardly ever passed, and the textile ones, like the socks, tended to pass. So I like the idea of talking about that this is angular, mineral opaque. It's in the vicinity of the small intestine, or where you'd expect the small intestine. Remember, the colon will come right through here. It can dip down, but it's in the area of the small intestine. It may be, where is this? L1. It may be right on midline here. Yeah, I don't know where it is on the VD. I don't know. So you go, I don't know where this is. It's pretty ventral. Remember, if the dog's rotated a lot, if you rotate that dog, it'll dip the colon down and you'll get faked out, right? But this dog is like only a little bit rotated, and that's pretty ventral. So the chances that that's a colonic origin, I think, are quite low. If you were really trying to be careful and you didn't want to get sued or whatever, you just do a pneumocolonogram, and that'll show you pretty well that that's not in the small intestine. But this doc wants to know, do you have to cut the dog? That's the big question, right? So just because you saw the foreign body, I think the loop that the foreign body's in is a little bit distended, but man, all these other loops are not that distended. Even though there is two populations, like this one's bigger than some of the empty ones, these aren't that big. I mean, it's not huge. And yeah, you could do a wooden spoon. Absolutely. That's a great guess. For those of you that don't know, wooden spoon technique, I love it. I love this wooden spoon. For those of you that don't know, you take a wooden spatula and you compress it on the area of interest while obtaining the radiograph. So you could literally flop this thing down right on here, push kind of hard. What it does is it displaces everything out of the way, and then you fire the radiograph, and that should help you as well. Maybe easier than finding one of those interns to blow gas up this dog's rectum. So I think the dog should be cut. The reason that I think the dog should be cut is because the stomach has too much fluid in it. It's not horribly distended, but this is the stomach right here. Okay, so the stomach is right here. It kind of goes this way. I kind of lose it. The cranial portion is kind of effaced. But this is the stomach right here. Left lateral view. You got a gas-filled pylorus on this view. So what this tells me is when you've got most of the small intestine that is empty, and this angular mineral-opaque foreign object that's in the cranial portion of the small intestine, and the stomach has too much fluid in it, that's telling me this is a proximal obstruction. If you wanted, you could do what this group did, which is hospitalize and repeat the study the following day. And what you'll find is that on this right lateral view, if the dog was appropriately fasted, this fluid is continuing to remain in the stomach, and the foreign body is continuing to remain in the small intestine. And it's right here to the right of midline. So here's the stomach right here, all the stomach. So you've got this persistent mid-cranial abdominal jejunal foreign body with persistent fluid-filled stomach. That tells me it's a proximal small intestine. What does the wooden spoon tell us? If you need more, the wooden spoon technique, real common for things like cystic calculi. So what it can do is it can displace things out of the way. So one of the things that may be confounding your ability to discern between colon and small intestine on this view is just the presence of other loops and the presence of the colon. So if you push, you start displacing things, the spleen, you displace other segments of small intestine, and you'll probably be able to do things like follow loops of small intestine, and you can better see if it is a small intestinal origin. The classic example is if you're worried that there's cystic calculi and you've got a loop of intestine overlying it and you're not really sure what to make of it, you can literally press on the urinary bladder and you will displace the small intestine, displace the colon, and you should be able to see if there's calculi, because the photons, the x-rays will fire. They'll go right through the wooden spoon. You'll see the spoon, but it'll be sort of this vague opacity and you can see right through it. So this dog should be cut. I don't think it was wrong for them to try supportive care because the degree of small intestinal dilation on this case is quite small. I think there's a loss of serosal detail right here. And so it's subtle. I don't really see it on that view. It just seemed kind of wispy right in here. And I guess I wouldn't be surprised if that the fat surrounding that loop was a bit angry. Dog got subcutaneous fluids. 13, 12, 11, 11, 12 right here is mineralized. And then this is a great case of a transitional lumbosacral vertebra. So you'll notice that this looks like the sacrum is super long. And if you hallucinate, there's a little physeal remnant. Not a physeal remnant, the junction between this lumbar vertebra and the sacrum, right? The sacrum should only be this length. So this is a transitional lumbosacral vertebra. And there's a faint transverse process. This is only really important for surgeons sometimes. you know, if this dog, once his back, there it is right there, 13, 12, 11, 11, 12, there's that mineralized disc. Once his back blows on him, it's important that the surgeon know that he's got symmetric ribs and the number of lumbar vertebrae that he has and so on. So interesting. So you you pulled off all the fluid, which probably made the dog feel like $1,000,000. Yeah. I wonder if it was a big dog. You know, this is a pretty small dog, and this is an angular. I wonder if that's like a tennis ball, or maybe it's bone. Maybe it's a little too opaque for a tennis ball. Yeah, I mean, sometimes you can play the game relative to what type of what type of foreign body it is. How big is the dog? Okay, this dog's acutely vomiting, worried about a foreign body. You always got a suspicion that maybe pyloric spasm. The dog's painful. Yeah, I noticed sometimes with foreign bodies that if you put the dog, at least I did when I was younger, I'd give the dog a low dose of like an opiate and walk him around, hold him overnight, give fluids, and then cross my fingers. And some of the times it would work. Okay, so here we go. Acute vomiting in a Labrador. He's about 5. They're worried. He eats everything. They're worried about a foreign body obstruction. Here we go. Okay. Anything? What do we think? We cutting this dog? We're not cutting the dog? Options are you cut him. Options are you do an ultrasound. Options are you maybe hospitalized, supportive care, repeat reds. Nothing. Go home. Come back if you're not doing well. Yeah, the dog is obese. He's an American Labrador, so that fits. I don't usually go nuts on serosal detail and VD view, especially in these larger dogs, especially well-fleshed animals like this. Everything looks like it's got everything looks like it's got a loss of serosal detail. So Doc Allen is saying we should do an ultrasound. Dr. Walsh wants to know where other sock is. I don't see the sock in this dog. I don't see a textile foreign body in this dog. I look at the caudal thorax. I say that that's normal. The gastric access, a little cranially positioned. So you start going, well, does the dog have microhepatica or microhepatia, whatever you say? He's a Labrador, so you worry about chronic hepatitis. It's tipped forward. So you just sort of go, okay, let's deal with that. Here's the stomach right here, right? Gastric access, you like it to be perpendicular to the vertebral column or parallel to the ribs. Other than that, you should start getting a little bit, excited. This is the stomach right here, right lateral view. It's got fluid in the pylorus, or it's empty and the pylorus is collapsed, and gas in the fundus. Okay, so this is only a mildly distended stomach. Sorry. And then you got the stomach right here. Okay, and then left lateral view, gas-filled pylorus. This is probably the duodenum, but I kind of lose it. So the stomach is only mildly distended with a little bit of fluid and a little bit of gas. Urinary bladder, small and fluid opaque. It's a male. Kind of look for the urethra here. We don't have the whole penile urethra, but we've seen crazier things. Okay. Kidneys. It's a mess. They're up here somewhere. They should be up here. Hard to see. There's probably one. Caudal border of the left. Hard to see. Not going to make it. Oh, here we go. This is one right here. And there's the left one right there. I don't see the right one. It's probably there. Feces right here. Follow this. You go up ascending colon, transverse colon, descending colon, which means all this is small intestine. All this is small intestine. Okay, so I'm glad nobody said the dog is obstructed, because I don't think the dog is obstructed. There is this sort of corrugated appearance to the small intestine and this caudal abdomen. Sometimes what I'll do is so you've got the small intestine here, and then when you go to this view, I'll still cheat, and you kind of look over and you go, well, what's it doing over there? Is it doing anything funny? And wow, the corrugation, it kind of goes away, right? So if it's not persistent on these lateral views, first of all, the loops are not overly distended. Maybe there's some corrugation that worries you. Maybe it's plicated. Maybe there's a linear component. And so what the folks did in this case is they just brought him back. And here are the follow-up fasted radiographs. Okay, I'm going to give you a couple of seconds, maybe a minute. We got a right lateral view. We got 4 views. Here we go. So you want to know what this loop is. Depends if vomiting, dull. Histories for suckers, Dr. Walsh. No history. Let's say the dog just came back in and they gave him to one of the nurses and they just took him in the back. On the VD, it looks like gas-filled colon. So this is freaking people out, right? So it's below 13, 12. It's kind of at an angle. Dog super rotated. So could be colon. I mean, look, you're seeing the underside of the spleen kind of come around like that. So this is in the area on the lateral view. You should say that this could be the colon. So here it is right here. That's in plane on the colon. The colon, this would be the descending colon on this left side right here. And so it's in the area expected for the colon on this view, and it's also in the area expected for the colon on this view. So you'd have to say it's the colon. If you can put something, it may not be the colon, not a perfect test, but on this test, you go, okay, maybe it's colon. All right, so now you hey Christine, is there a huge delay? I apologize. It's a shoestring budget here. Okay. All right, everybody. Shoestring budget. I wonder if she's, look at the delay. Anyway, so Dr. Allen's still going to ultrasound. So now you take the rad, you look at him, you go, oh boy, what's this loop right here? Okay. And then you run back out and they say that the dog hasn't vomited at all overnight. Stomach still has fluid. I don't think the stomach has very much fluid at all. I think this stomach is, look at those rugal folds, right? So it's pretty collapsed. I think actually the stomach has no fluid in it. I think the stomach has no fluid. Where is this thing? This looks like fluid, but it's just the pylorus. It's like the whole atelectasis of the stomach. There's no gas in there, and it's collapsed. And when you put these up side by side, what you'll notice is that the shape of this one, on the left, you've got the recent ones, and on the right, boy, there's not a lot of fluid in either. Maybe there's a little bit of fluid in there. That's not super black, super radiolucent. I don't think there's any fluid in here. I think that thing is squeaky clean. There's rugal folds right here. And then none of the small intestine is more distended. So for me, if you can work through what's this loop, who does that belong to? Again, you can do a pneumoclinogram. Dog's not gonna love a compression radiograph through his ribs, so that's not not gonna work here. And if he's not better, then you can do the ultrasound. But I think on the follow-up rads, this is definitively not obstructed. Other things to kind of show you, these right here, these little thin little areas of love right here that look like nothing. It's a circumferential femoral head osteophyte, this thing right here. And here's another one. Okay, that looks like nothing on histo. It's just a chunk of new bone formation where the joint capsule inserts on that femoral neck, and it should raise concern for some degree of laxity in the joints, though they otherwise look totally normal. I got a case that's really difficult that I'm hoping. Oh yeah. Oh boy. This one's gonna be very nice. Okay, so 3 views. We've got a I don't know, what kind of dog was this? I forget. It's a small breed dog, maybe a Chihuahua. Respiratory distress. And you're trying to figure out, is this upper airway, lower airway, both? What's going on? What do I got to do? I will tell you that in terms of difficulty, this is one of the more difficult cases. So don't beat yourself up if you don't get it. But I'm presenting it with you. Afterwards, I'll present another case to compare a certain feature of this case, and hopefully at least it can drive home one of the points. Okay, here we go. All right, you guys want to jam? Let's do it. What do you think? Dr. Allen's going lower. Dr. Walsh is going a bit lower. Okay, I like this one. Okay, so all right, first of all, the dog's obese. Second of all, he's expiratory. When you blow all the gas out, the blackness of the gas is what you want to contrast with the white of the disease, right? So already you're up against it. This stomach has got a lot of gas in it, a little bit of fluid, a lot of gas. Probably aerophagia because of the history of respiratory distress. So you got an obese dog, it's expiratory, he's gasping for air. A little bit too much here. I think it's a little bit too much liver. It's just a little bit, I don't know if he, his gastric axis is fine. It just looks a little swollen. This is an abnormal lung pattern. This is an area that's often overinterpreted because the patients that are expiratory and obese, but this is a real, I think, lung pattern. He's also rotated. I think that there's a real lung pattern. I think on this view, you can't see it so well because we don't have as much gas to outline the opaque lung pattern. So I think there's a real subtle lung pattern, and you wouldn't be wrong to say that I don't see a lung pattern. So the feature that I wanted to show you on this test, which I've talked about on several tests, on several episodes before, is right-sided cardiomegaly. Okay, so if you see this cardiac apex, okay, this is a right lateral radiograph. This cardiac apex, it should pin itself down. First of all, right-sided cardiomegaly is not common, and I mean, I may see a couple a month, and that's reading, maybe 1,200 studies a month, 1,000 studies a month, something like that. So it's really not common. I feel like I don't see it a lot. Tons of left-sided congestive heart failure, not a ton of right-sided cardiac disease, especially pulmonary hypertension. But this cardiac apex normally should stick on the sternum on a right lateral view, okay? On the left lateral view, the cardiac silhouette apex normally is rotated dorsal from the sternum. So when you see that dorsal rotation on the left lateral view, that's fine. I think I saved this one because if you see this right lateral view on this normal cardiac silhouette, so this thing is down here, okay? This left lateral view, see how it's rotated away? So you can't really see it. It's because it's sort of tipped away. And this one you can kind of see. It's a little bit more flat. Let's see if I can find another one. What's this one? Oh boy, check this one out. Right lateral view. Look at this sucker. It's just pinned on the sternum. Okay. Left lateral view. It's kind of a little bit indistinct, a little blurry, using the wrong term. So this apex is stuck on the sternum. If we go back to this view, oh, look at that thing. He swung up. She, he, they, it swung up from the sternum. So that's a great indication that you should be alerted to on a right lateral view. If the cardiac apex is deviated dorsally from the sternum, you should start wondering about right-sided cardiomegaly. This breed will tend to look like he's got right-sided cardiomegaly because they're boxy. He's fat. There's expiratory phase. All these things would make you think incorrectly, give you a false positive that there's right-sided cardiomegaly. But this apex deviation it's game on. And I think on well, I thought I had, well, screw it. I think this was a follow-up study. The other study had a really good MPA. So I'm just going to tease you with that. The MPA bulge would be 1 to 2 o'clock. So it had a good bulge on this one. I think this was a follow-up radiograph, but this is what I wanted you to take away from it. This right here, you should worry about the fact that this dog has, right? So this is normal right lateral view, stuck. Left lateral view is rotated. Right lateral view on this study, it's rotated dorsally. Okay, so the lung pattern in this case is most likely the result of sildenafil responsive pulmonary infiltrate. So they get an edema secondary to sort of these high pressure pulmonary hypertension. In my experience, they tend to be more chronic, not like a PTE pulmonary hypertension. I think this dog has right-sided cardiomegaly secondary to pulmonary hypertension, and I think it's chronic, and it's resulted in this sort of incredibly paradoxical caudodorsal sildenafil responsive pulmonary infiltrate. So if you give the dog Lasix, it improves it, but they really need sildenafil to take away that pressure, and it'll help reduce the fluid load in the lung. So they have edema, but it's not from your traditional left-sided heart failure. It's a right-sided thing. And when I first read about it, my head exploded. And so this, I think, is concentric hypertrophy, which the wall gets thick, and so it kind of grows inside. And those are harder to detect radiographically as opposed to like a eccentric hypertrophy. You'd think mitral valve disease. Eccentrically, it's too much volume. The lumen gets big and it just gets really huge, and it's very easy to see. These are more difficult. So yeah, I think right-sided enlargement. So you're looking for ascites if you're worried about cor pulmonale, so you get right-sided heart failure from this sort of over pressure of the lung. It'll cause it'll cause hepatomegaly, and you will get ascites, but I don't see any ascites in this dog. But this could be swollen, this liver, because of congestion. So this dog does need an echo. This dog does need sildenafil. And I feel like, I've gotten better at recognizing subtle cases of right-sided cardiomegaly, because when I look at all of these cases, especially when I think that the cardiac silhouette is enlarged, a lot of times most of our clients are specialty clinics, and so they've had cardio consults. And so when I go and I start looking for the medication, it's typically at the top of our histories. And so I look, and I'm just looking for sildenafil. Dog's limping. He's an old dog, and he's limping. Oh, you get one view as well. Anybody got anything? Anybody got anything? Yep. Location, nice. Röntgen signs, nice. Monostatic, nice. Yeah. Nice. Stock. Yeah. So here's how I would approach this one. First thing you do is you say the location. So it's distal left tibia, but the real severity of disease you could imagine is sort of in here. But if you're not sure, it's definitely different than sort of mid-diaphysis, right? So in the distal metaphysis, this is how I would describe it. In the distal metaphysis, there's an aggressive bone lesion. The aggressiveness is characterized by medullary and cortical lysis, as well as spiculated/irregular periosteal reaction. The zone of transition is indistinct. I'm also worried, I wonder, given the severe soft tissue swelling, if you took an orthogonal view, if there's a path fracture. And that's important for helping narrow the possible therapeutic options. Radiation is not going to be a good option for this dog. So it's likely arising from the metaphysis. You can't say that for sure because it's sort of incorporating a large portion of the bone, but it's important to discern between diaphyseal and metaphyseal, because metaphyseal tends to be your usual suspects: bone cancer, primary bone neoplasia. So osteosarcoma, chondrosarcoma, fibrosarcoma, and hemangiosarcoma. It could be mycotic if you're in the Southwest US or other places, and probably less likely bacterial osteomyelitis. Okay, so you could probably harpoon this thing with a needle and not necessarily biopsy. But I'm worried about a path fracture given the severity of swelling. There's muscle atrophy. There's the gastroc, or what's left of it. Here's the popliteal lymph node. So there's concern for Mets. There's a bit of heterogeneity to the soft tissues here, and some of that's from technique. See how it's really burned out, overexposed. It's in the oven too long. But there's the left popliteal lymph node. It's way too big. So you got atrophy of the muscle, probably from disuse. You probably have a path fracture. So monostatic aggressive osseous disease of the distal aspect of the left femur. Prioritize bony neoplasia, concern for metastasis to the popliteal lymph node. You could do an orthogonal view to help determine if there's a path fracture, and thoracic radiographs to look for pulmonary mets. That took a long time to present. Yeah. This dog, I think the history actually said he got away for like a month and he came back limping. But this is not good. So features of aggressiveness, right? You got medullary lysis, cortical lysis, indistinct or sort of long zone of transition, the periosteal reaction. This sort of smooth continuous, or Codman's triangle that Dr. Allen referenced, that smooth and continuous you tend to equate with sort of inactive or chronic and non-aggressive. It's these irregular, the spiculated, irregular, discontinuous stuff that's more an aggressive feature or an active periosteal reaction. You don't need to have all of those features to say it's aggressive. If you have an irregular periosteal reaction, an irregular periosteal proliferation, you've got a feature of aggressiveness. So this has a lot of the features of aggressiveness. So location is important. Do you have any of the features of aggressiveness? Looking for Mets, the location, monostatic versus polyostatic, age of the patient, all helpful. Okay, let's do another case. This dog is tachypnic, and he's kind of collapsed. You got 4 views, orthogonal of the thorax and orthogonal of the abdomen. Dr. Walsh says it's hard to interpret cervical vertebral abnormalities. Depending on the abnormalities that you're wondering, I mean, if you're talking about disc disease, it's really difficult because the positioning is usually shit. It's totally terrible. This dog looks like all of his disc spaces are collapsed, but it's just because he's and case in point, this is the dens. You in a perfectly positioned lateral view, you don't see the dens. Right, so this is a wing, and this is starting to be this is a wing, and that's the other wing of C1. So the dog's just like rotated, and this is an ear. And so the fact that you're seeing the dens tells you that he's rotated. So cervical radiographs are difficult because they're just the positioning it tends to be very difficult to get, and nobody really wants to sedate or anesthetize the animals. This dog, let's take out the thoracic. Okay, this cardiac silhouette's too big. Okay, the thoracic trachea is deviated dorsally, suggesting a left ventricular enlargement. The left atrium, this is it. It goes way up here. Okay, this is it. So moderately enlarged left atrium, dorsal displacement of the thoracic trachea. I'm going to go over here to the VD. Here's the increased opacity in between the principal bronchi, or main stem bronchi, if you will. So here's the trachea. Carina. There's the right caudal lobar bronchus, and then the left over here. So this opacity is increased soft tissue opacity in the area of the left atrium. We know that it's the left atrium and not, say, tracheobronchial lymph nodes, because when you go back over here, this trachea goes way up here, and this area is not displaced ventrally. So if you had a large tracheobronchial lymph node, it would be jamming this down, not swooshing it up. So this is a big old cardiac silhouette. I'll flip over and show you on the VD view, the left auricle, 2 to 3 o'clock, subtle bulge. Dog's rotated a little bit. There's his sternum. You don't see the teardrops. So he's a little bit cocked to one side, but there's a subtle bulge. I wonder if you straighten him up, it gets a little more bulgy. The right caudal lung lobe kind of caught my attention for maybe subtle edema, but I wasn't really sure. The next one is, I'm very sure, if I can just click with this shitty internet, this dog has peritoneal effusion. Okay, you just can't see the margins of anything. I don't really see the urinary bladder. Okay, you can't see the margins of the liver. You can't really see the spleen. And then you've got this sort of heterogeneity over here. If you look on the VD view of the abdomen, there's a lot of goodness. I mean, look at all that. That's just that wispiness. This belly is full of fluid, but this sort of wispiness or heterogeneity can help you feel more confident that it's fluid. Plus, if you're like, well, is this serosal detail that's reduced because the patient is thin? Well, he's not really thin, and plus the abdomen is quite distended. So it's a belly full of fluid, okay? So I think the dog has moderate left-sided cardiomegaly, maybe a little bit of right-sided component, but that could be from left-sided, chronic left-sided disease. I wonder about low-grade left-sided heart failure to cause edema in that right caudal lung lobe. So you do a DV radiograph, but it's not definitive by any means. But the presence of cardiac disease and the presence of peritoneal effusion, you should at least sort of wonder, does the dog have right-sided heart failure? Does the dog have cardiac tamponade? There was a report that I talked about not too long ago where I think classically we think dogs with pericardial effusion have to have a globoid cardiac silhouette, but that's not true. It depends on the volume of effusion and the chronicity. So if you have a decent volume over time, it will stretch the pericardium. If you have a clinically relevant volume that happens acutely and the pericardium hasn't had enough time to stretch, you're not going to have a globoid heart. So on this particular case, I would worry that there's right-sided congestive heart failure, cardiac tamponade, because there's the cardiac disease. So you should do an abdominal ultrasound and look for and sample the peritoneal fluid and look for evidence of neoplasia. There's a ton of fluid, so I don't think this is like pancreatitis unless the dog had like vasculitis, hypoalbuminemia, hemorrhage, sepsis, neoplasia, right-sided congestive heart failure / tamponade. Yeah, this is gas overlying the vertebral column. You know, this loop right here is a little bit corrugated. You see how this is nice and smooth and sort of nice and smoothly undulating. And this is more like a little bacon strip. So this loop is pissed. It's angry. And so it's reacting secondary to either the peritoneal process or intrinsic intestinal disease, or both. This is the colon. Okay, this is the big stomach. Yeah, I don't think I'd be worried that there's an acute abdomen heart is incidental to collapse in the kidney. Yeah, because I think some of the salient features of the is this the cardiac silhouette? Is that cava not huge? You know, if you're worried about something in front of the liver causing congestion, typically this gets, you know, a little bit enlarged. Let's see if it's on this view. It's not horrible. So yeah, I think the other thing you can look for is gallbladder wall edema. A lot of times with right-sided or post-sinusoidal, we say post, so after the sinusoids of the liver, post-sinusoidal, anything on this area causing congestion can cause dilation of the vena cava, the intrahepatic veins, can cause gallbladder wall edema, not just anaphylaxis or sepsis or hypoalbuminemia. I think portal hypertension can do it as well, but a post-sinusoidal process can do it. But yeah, this is a little subtlety right here. I don't know, but a DV radiograph. You can see the bacon strip right here, the corrugation right there. It's kind of ratty. That tells you that the intestine's pissed, not happy. Gastric access is fairly parallel to the ribs, so you're not getting this impression that there's a very large, hepatomegaly. So I don't think it's wrong to wonder if this is not cardiac related. His elbows look maybe like they got a little bit of OA. Okay, I think we're done. We're off. I got to eat dinner. It's freezing cold on the East Coast. I'll look for some necks. On right lateral view, it looks like it's sitting on the sternum enough. Yeah, talking about the right heart. Yeah, I mean, this dog, I wouldn't say that this is like a slam dunk cardiac related process. And I don't know. I just think that it's, I think in this particular case, you don't want to just look in the belly. I think if you did look in the belly and you didn't really find anything that was obvious, and then you did a peritoneal abdominocentesis and you pulled it out and it didn't look like it was hemorrhage or it had a lower protein that made you worried that it was, related to a post-sinusoidal process, then I think you could get there. You can also shoot for the pericardium through the diaphragm and see if there's pericardial effusion to cause tamponade. I just think that it's important, even though there's not pleural fluid, even though the cave is not overly dilated, even though I'm not worried tremendously about right-sided cardiac disease, I think with a lot of peritoneal fluid in a dog that has cardiac disease, it makes sense to at least make sure that you don't have a cardiac-related process. But I think this case needs an echo, and this case needs an abdominal ultrasound. Okay, ciao.